resident at King Faisal Specialist Hospital and Research Center. Today I'm presenting a case report and literature review of a pediatric patient with spinal ABC that was treated successfully with Denosumab. A quick refresher regarding aneurysmal bone cysts. They are benign expansile lesion with unknown etiology. They usually present secondary to mass effect or expansile destructive activities. Their characteristic finding on imaging is fluid level on MRI. The gold standard of management is surgical resection. Our case is of an 8-year-old female patient who presented to her local hospital with a history of neck pain following a fall. Upon examination, she was found to have a large posterior neck mass and no neurological deficit. X-rays were obtained showing loss of cervical spine alignment and near total destruction of C3. CT is showing more of the same. MRI showing the characteristic finding of ABCs, which is fluid level, as you can see here, in addition to some compression by the anterior elements of the cervical spine on the spinal cord itself. CT-guided biopsy was obtained and confirmed the diagnosis, after which the patient underwent front-back 360 surgery, whereby a C3 corpectomy and iliac crest bone graft and plus anterior plating was done, and afterwards a posterior lesion resection and instrumentation from C2 to C5 was performed. Unfortunately, upon follow-up, the patient was found to have recurrence. As you can see here on imaging that were done 3 months after the surgery. The patient was referred to our hospital, to medical oncology, and while she was waiting for her appointment, she presented to our ER with a new onset of symptoms of bilateral shoulder weakness that was worse on the left side and decreased sensation in both upper limbs. She also had positive Hoffman and sustained clonus. Urgent MRI was obtained for the patient while she was in ER, showing recurrence of the lesion, as you can see it here, both on axial and sagittal fuse. While in ER, she received dexamethasone as per protocol and then was transferred to our colleagues in interventional radiology for selective arterial embolization. Unfortunately, no predominant blood supplier could be identified, so 3 feeders were embolized and no more, as there was a risk of injuring the vertebral artery or embolizing the vertebral artery. The patient was booked for emergent surgery, whereby she underwent marginal resection of the tumor on both sides plus cord decompression. The construct was deemed to be stable, so there was no need to revise it. Marginal resection and not complete resection was done was due to the risk of injuring the vertebral artery if we attempted total resection. Post-operatively, the patient was examined and was found to have complete resolution of symptoms. The patient was referred to our colleagues in medical oncology, and after a lengthy discussion, she was deemed to be a good candidate for Denosumab. Now, a quick review of Denosumab. It's an anti-rank ligand monoclonal antibody that is FDA approved for adult use for treatment of bone mets, osteoporosis, and giant cell tumors. The regimen that we used is for this patient, which is a pediatric patient again, is 70 milligram per square meter per dose, which is around 60 milligram weekly for 4 weeks as a loading dose, and then monthly afterwards for a minimum of 12 months, and this regimen was supplemented by vitamin D and calcium carbonate. Now here's the follow-up CT for our patient that showed decent calcification of the mass and some kyphotic deformity as well that we deem to be acceptable. Now, in terms of literature review, we found no consensus on regimen for the pediatric population. While the adult patients receive or follow usually the same protocol for giant cell tumors, which is 120 milligram as loading for the first month, which is weekly dose, and then monthly afterwards as a maintenance. The pediatric regimen varies. The 2 main reported regimens is the one we used. The other one is 1.2 milligram per kg per dose weekly and progressed 1.6 milligram per kg per dose in 1 month and then continue as monthly. Now, the reported outcome is very promising. All articles reported radiological and clinical improvement. Furthermore, denosumab is found to have a relatively safe profile, with rebound hyperglycemia being the most serious reported complication. However, the recurrence rate is estimated to be around, or calculated to be around, 17.2. Now, the only issue with these studies is that there is no level 1 or 2 evidence. Also, they are not standardized. Um, what we mean by this is that the regimen is not the same in all papers, the length of follow-up is not the same, the length of treatment is not the same, and there isn't enough differentiation between primary aneurysmal bone cyst or secondary aneurysmal bone cyst, as in terms like secondary to another lesion, such as ossifying fibroma or osteoblastoma. So, bottom line, further research is warranted in this field, especially if we're talking about pediatric use of denosumab for the treatment of aneurysmal bone cysts in the spine. Thank you for listening, and that is all.